Welcome to a course from Seating Dynamics, Muscle Tone and Tone Management, Dynamic Seating Intervention. My name is Michelle Lang. I'm an occupational therapist in the Denver, Colorado area. I provide some consultation for seating dynamics. I also use dynamic seating with the clients that I work with. Welcome to this course. It is approved for CEUs. Some of you are watching this live and some will watch it on demand later, and we're glad that you can join us here today. So we have the following learning outcomes as this is approved for CEUs. 1, the participant will be able to define muscle tone and related pathophysiology. 2, the participant will be able to list 3 tone management strategies. And 3, the participant will be able to describe how dynamic seating interventions can benefit clients with increased muscle tone. So this is the first of 2 series, 2 courses in a series on this topic. In today's course, we're going to talk about just what is muscle tone, tone management strategies and their impact on positioning, and then dynamic seating intervention for clients with increased tone. In part 2, and we have not yet determined the date of that course, general positioning strategies for clients with increased tone will be reviewed. So how will you receive your CEUs for this course? Well, if you've registered through our website for this course, then after watching this, you will receive an email with a link to a post-test. Once you complete that, you'll receive your CEU certificate in the mail, via email exactly, through NARTS. NARTS has approved this course for CEUs. So positioning a client with increased tone. If a client has increased muscle tone, this is going to impact what seated position is selected by the wheelchair seating team and what strategies are then used to achieve and maintain that position over time. Let's start with some definitions. It's real important that we're on the same page in terms of just what is muscle tone, what causes it, etc. So we all have tone in our muscles all the time. The muscle is in a steady, partially contracted state that's caused by a successive flow of nerve impulses, and those nerve impulses go in 2 directions. So, for example, you're readily able to keep your jaw closed without even thinking about it. There's a certain amount of tone in those muscles around your jaw that ensures that your jaw stays in a closed position and doesn't just hang down. Muscle tone can also be defined as the amount of tension or resistance to movement in a muscle and muscle resistance to a passive stretch. This is often how we determine the amount of muscle tone in a client. So muscle tone is controlled by 2 different factors. First, there are inhibitory signals that come from the brain through the spinal cord and to the muscles. They release a specific neurotransmitter called GABA, G-A-B-A, and that helps the muscles to relax. So it inhibits muscle tone, muscle activation from the central nervous system. There's then excitatory stimulating signals that come from the muscles themselves, and these travel up the spinal cord and tell the muscles to contract. So if the balance between these 2, between the muscles and the brain and spinal column, are normal, then muscle tone is normal. Let's talk about some more terminology. Hypotonia means decreased muscle tone, where hypertonia means increased muscle tone. Rigidity is where there's tone on both sides of a joint, in both the flexors and extensors. So it feels the same, really, whether you are extending or flexing that muscle, and it's non-velocity dependent. It doesn't matter how quickly you move the muscle, it's going to have the same feel in terms of amount of tone, whether you move slowly or quickly. Spasticity is often used interchangeably with hypertonia, but it actually means muscle spasms, which are increased by movement, which is different than a general overall tone in the muscle. And then we have velocity dependent tone. This is often seen in people with conditions like cerebral palsy, where quickly moving that muscle, that limb, like straightening out someone's arm, elicits a stretch reflex, and that leads to an increase in muscle tone. So if you move that same joint slowly, you may not feel as much resistance, but if you move it quickly, you do. All of our muscles have a stretch reflex. That's to protect our muscle. A muscle holds on, it grabs if it's suddenly stretched to protect your muscle from damage like a tear. For people who have a condition like cerebral palsy, that stretch reflex is greatly heightened and it's very easily elicited. So what just exactly causes an increase in muscle tone? Well, if there's not enough inhibition to the muscles from the central nervous system, that's the brain and spinal column, then that results in excessive contraction of the muscles because that GABA, that neurotransmitter, isn't coming down and inhibiting those excited muscles. And this is due to damage somewhere in the brain or the spinal cord. What impact does increased muscle tone have on people that we work with? Well, pathophysiology is a discussion of what is the impact of this condition on the body and someone's function. So there's an effect on growth. When muscles are tight, and those muscles are attached to bone, as the bones attempt to grow, they're influenced by these tight muscles. And this can lead to asymmetries in the length of a bone, like the femur. It can also lead to rotation of a bone. So we have a child who is quickly growing. Perhaps they've hit puberty and there's a large growth spurt, and the muscles are pulling on those growing bones and will influence what happens. Rotation of the femur, which is very common because of which muscles tend to be tight in that hip and lower leg area, lead to rotation of the femur oftentimes, and that can lead to hip dislocation, particularly in conjunction with someone who perhaps is non-ambulatory and has a real shallow hip socket, and where the head of the femur is straighter and not as angled as in weight-bearing peers. We can also see spinal asymmetries. So if there's more tone on one side of the spine than the other, it's going to pull on that side of the spine, and that shortening of those muscles leads to a chronic position in asymmetry, and before we know it, we have a spinal curvature. So this is particularly common in children, especially during growth spurts. In combination with these asymmetries in tone, we also have the impact of gravity and perhaps inadequate support for somebody who isn't able to keep their trunk upright against gravity. Range of motion. Well, if you've ever perhaps broken your arm and had to wear a cast for a long time, you know that when that cast came off, it wasn't too easy to straighten your arm again. And it might have taken therapy and long hot soaks and a lot of work to regain that lost range. For many of the clients we work with, these tight muscles tend to pull joints into a flexed position. Then we place someone in a wheelchair seating system and their hips and knees are flexed for long periods of time. And often that same person may end up sleeping in that position. So throughout their 24/7, we have someone who's in positions where certain muscles become shortened and we lose full range of motion. So if the joints do not move to full range often enough or for long enough periods of time, range is lost. It's particularly common that this occur during growth, and range loss is often worse and can occur very quickly if someone has very high muscle tone and rigidity. Now, all of us have a certain amount of inherent stability. I'm able to sit up right now because I'm balancing what's going on between my abdominals and my back muscles. And if I can't, I'm going to fall over. I'm not able to maintain my position well. So we tend to stabilize and balance our bodies by balancing muscle groups. How much is going on? How much muscle activity is in each one? Co-contraction is that balance between muscle groups. But if muscle tone tends to be high in flexors, for example, like maybe high in this bicep, then the extensors, the opposing muscle group, is less active. And that's going to impact someone's stability and balance. We can see this anywhere in the body. It particularly is problematic in trunk control. If someone can't balance their back and abs well, then they're going to have difficulty with trunk control, often head control as well. What about the functional implications that we're looking at here? Well, with someone who has increased muscle tone, depending on the areas and severity of involvement, we can see an impact in ambulation, gross motor control, fine motor control, stability and balance, trunk and head control, feeding, swallow, really just about everything. And then in combination with this, the cause of the increased muscle tone may lead to other issues as well. So if there has been damage to a part of the brain that's led to increased muscle tone, it could lead to other issues as well, like visual issues, for example. So it's important that we understand that increased muscle tone can have a profound impact on function in a variety of areas. Each person's an individual. We have to recognize how that increased muscle tone has impacted them and then provide the appropriate intervention from there. Now, something that also is very common in people who have increased tone are movement disorders. Movement disorders that we commonly see with people who have increased muscle tone include athetosis, dystonia, chorea, and ataxia. So I'm going to start this video here and we'll make it quiet. Come on, video. There we go. So athetosis is a slow, writhing motion of the fingers, the hands, and is often seen around the mouth. It's more continuous than we see in people with dystonia. And this impacts about 5% of people with cerebral palsy and may be due to damage to the basal ganglia. Now, I've been doing this for a long time, over 30 years. And so when I was first doing occupational therapy, we thought that just about any movement disorder we saw in someone with a condition like cerebral palsy was athetosis. But there's more clarity now on just what is athetosis, what is other movement disorders. And again, this is not as common as other movement disorders with this population. Dystonia is more common, though still is only seen in 25 to 35% of people with cerebral palsy. In dystonia, we see more sustained muscle contractions that result in twisting movements and abnormal postures. And Amber is showing you both extension and dystonia in this video here. It may affect only one region of the body. It may affect adjacent body regions, one side of the body, or even all of the body, and is also thought to be due to damage to the basal ganglia. I'm going to go ahead and move this video along so we can get a better sense of people with more significant chorea. So in chorea, which is very common in people, as in this video, who have Huntington's chorea, we have an involuntary, abrupt, rapid, brief, and unsustained irregular movement. This was initially described by the first people who gave this a name as resulting in dance-like movements in people. 5% of people with cerebral palsy have chorea. And again, this can be much, much more common in people who have conditions like Huntington's chorea. And again, that's being demonstrated in this video. So this is thought to be caused by damage to the basal ganglia again, but a different region of the basal ganglia. We then have ataxia, and ataxia is an abnormality of coordination, and it particularly impacts walking. So this can be seen sometimes in people with increased tone as well. This is thought to involve the cerebellum, which has a lot to do with our coordination of movement. So this video is showing someone with ataxia. Now, movement disorders are non-progressive, with the exception of some metabolic disorders where we can see a change and worsening. Certainly, we see a worsening in people with Huntington's chorea. Stability and positioning is really, really important. So if you're working with someone who has a movement disorder, this person is lacking a lot of stability, not just because they are lacking co-contraction, let's say, balancing those muscle groups, but because those muscles leading to these movement disorders are fluctuating in their amount of activity. And that makes stability near impossible. So it's very important to provide lots of stability within the seating system to help this person to be as functional as possible because they simply can't stabilize themselves. Another thing that's important to remember is cognition is often average to above average in people with many types of movement disorders, not always, but particularly in athetosis and dystonia. So it's important to keep that bar high. Let's talk about reflexes. So reflexive or obligatory patterns of movement are commonly seen in people with high muscle tone. This can include reflexes like ATNR, STNR, rooting reflex, stepping, and there are various causes for this, pathology, and functional implications. So let's look a little closer here. In terms of etiology, these reflexive responses, sometimes called primitive reflexes, are present in infancy, often to aid the child in certain tasks, such as nursing. So, for example, the rooting reflex, if I feel a touch on my cheek and I have this reflex, I'm going to turn, and that can help again with nursing. These typically fade away or are integrated as a child gets older. But in some of our clients, this may not happen, either because there's damage to certain areas of the brain that prevent this. It could also be that because there's a lack of typical motor development and movement that would integrate those reflexive responses into our brain, that may not happen. Lots of us have some persistent reflexive responses, especially under duress. Some of this can still kind of peek out. Pathology. Reflexive responses are non-progressive. They're persistent, obligatory patterns, and this can lead to orthopedic changes and even range of motion losses as it drives the pattern of movement that we see in an individual and makes it difficult for that individual to really isolate voluntary motor control outside of these patterns. So in terms of function, we might limit volitional control, see limited control because of these obligatory patterns. ATNR, that fencing position, can really impact someone's visual regard for what's in front of them if their head is often turning to the side along with their eyes. And there's certainly seating implications. So we're going to often try to position someone so that they are less likely to be triggered to have these responses. So some of these reflexive responses, for example, are triggered by the position of the head in space, and that person may simply not tolerate being tilted or reclined beyond their head being upright without these reflexive responses. Let's talk some about these diagnoses. So diagnoses that include high muscle tone include cerebral palsy, traumatic brain injury, multiple sclerosis, certain metabolic disorders. And we can see isolated high tone in people with spinal cord injury and stroke. So in cerebral palsy, there's damage that occurs to the brain before, during, or shortly after birth. We have a lot more idea of the etiology of cerebral palsy now than we used to. Often there is a metabolic or brain development issue that occurs well before birth as well. This can be due to hypoxic or anoxic injury to the brain. Children have very plastic brains. Neuroplasticity allows certain areas of the brain to learn how to take on functions of areas that might be damaged. And so early intervention becomes very, very important. There's a lot of different types of cerebral palsy, and they're often defined by the area of involvement. In CP, muscle tone can be high, it can be low, and often is mixed. So we might see high tone in the extremities, low tone in the core, and that's a mixed presentation. And it can make seating very challenging. Tone, as we mentioned before, is velocity dependent. If we give a quick stretch, then we're going to see a sudden increase in tone if there's any resistance to that tone. Tone typically relaxes at rest or during sleep. There's an increased stretch reflex and movement disorders, and those reflexive responses are very common in this population. Traumatic brain injury is where injury to the brain occurs, and this is due to trauma, hence the name, but it does include hypoxic or anoxic events. Hypoxic, where the brain doesn't get enough oxygen for a period of time, and anoxic, where there's no oxygen for a period of time. This can include non-accidental trauma and post-drowning. If this occurs close to birth, sometimes up to 2 years old, depending on the doctor, this can be classified as cerebral palsy or traumatic brain injury. Muscle tone tends to be very high and non-velocity dependent in this population, and rigidity is very common. Multiple sclerosis is where there's demyelination along the central nervous system nerves. The axons are spared. So when a baby is first born, their movements are rather jerky and not coordinated, and their nerves are not yet fully myelinated. Myelin is like insulation along the nerve, and it helps those signals move smoothly. Without it, those movements are not smooth and coordinated. But with multiple sclerosis in an adult, myelin begins to be lost in certain areas, and that can leave those areas scarred or sclerotic, hence the term multiple sclerosis. And these areas where myelin has been lost are called lesions or plaques. If the motor nerves are damaged, then high tone can result. This can lead to damage of motor and sensory nerves. And that tone tends to be high, non-velocity dependent, and rigid. Certain metabolic disorders also can lead to damage of the inhibitory pathways coming down from the brain and spinal cord. This can result in high or low tone. Typically, high tone is non-velocity dependent and rigid, and it can be progressive depending on the nature of this disorder. Movement disorders and abnormal reflexes may be present. It's going to depend on that individual. What about spinal cord injury? Well, a long time ago, when I thought about spinal cord injury, I figured, well, the spinal cord has been severed, and there certainly can't be any tone going on below. But as I became hopefully a little wiser and learned more about spinal cord injury, realized that, again, muscle tone is a two-way communication from the muscles to the brain and spinal cord. And there can be isolated areas of high tone, particularly in people that have a partial injury to the spinal cord. High tone or muscle spasms may be triggered by certain events, including a positional change, such as opening the seat to back angle or reclining. So you might notice as you recline a client with a spinal cord injury that there may be an increase in tone, there may be spasms, there may be clonus. Clonus can be seen in numerous areas. It's more common in the ankle, and we just have this kind of rhythmic beat, and it's often controlled by simply flexing the ankle. And then finally, in CVA or stroke, spasticity may be seen on the involved side. We can also see flaccidity, where we have very low tone. This is non-velocity dependent and can be rigid. As a result, this person may lose range very, very quickly. So in a stroke, we have a stroke on one side of the brain and we see the involvement on the opposite side. So if someone has had a stroke in the left side of their brain, we'll see these changes in the right side. It could be that we mostly see this in the upper extremities, but it often involves that entire side of the body, hence hemiplegia. All right. So lots of information about what is muscle tone, what causes it, what are the definitions of hypertonia, hypotonia, spasticity, etc. And what does this actually look like in the clients we work with, depending on their diagnoses. Now we're going to talk about some of the medical interventions that are available that impact positioning for clients with increased muscle tone. Now, I'm not a physician, I'm an occupational therapist, but I want to share this information with you. I find this information is very helpful to me when I'm working with my clients because I need to work hand in hand oftentimes with the medical team to know what's going on in terms of tone management and how that may impact our seating decisions. So tone reduction is often accomplished through oral medications, and there's a number of them on the market, but the three that are probably most commonly used in the US right now are baclofen, tizanidine, and diazepam. These result in a global impact on tone. In the seating system, we might see a reduction of overall extension. But this can also lead to lower tone in the trunk and neck, particularly in those clients that have a mixed presentation of low tone core, high tone extremities. We may also see an increase in secretions. This is an area where, again, I work closely with the medical team. So perhaps the medical team is slowly increasing the amount of an oral medication. And all of a sudden I notice, boy, my clients just lost a tremendous amount of head control and their secretions are quite extreme. I might report that back to the medical team because that gives them the feedback they need to know that perhaps that's a little too much tone medication for that individual and they need to back off a little bit. Again, I'm not a doctor. I certainly don't say I think they need less baclofen. I just say this is what I've noticed and let the doctor make that decision. Also common in tone reduction are injections, and this provides a more targeted impact on tone. Common injections include phenol and Botox. Phenol, when it's injected, temporarily destroys part of a motor nerve. So not as much information gets to all those muscle fibers in the muscle belly, and we have a temporary reduction. Phenol is a disaster if it gets too close to a sensory nerve. So when the rehab physician is deciding between phenol and Botox, if this is a muscle where the injection needs to occur, where there's a lot of sensory nerves in that area, they'll often use Botox instead. Phenol's usually used in larger muscles. Botox temporarily destroys certain muscle receptors in the muscle belly. And so even if there's excitation occurring within the muscle that isn't being calmed by the central nervous system, there's only so many muscle fibers that can be triggered because the muscle receptors have been temporarily damaged. This is temporary. It will regrow. The impact can last differently depending on each person, but is often around 3 months, and then the client will get perhaps more injections. Now, with Botox, there's only so much that can be injected into a person depending on their size. So, particularly for someone who's smaller, it's important that the team decide what muscles are the priority right now. Now, this has a targeted impact. It's going to impact one area of the sitting posture, but we might see an overflow impact. So, if we can relax one muscle, like the hip adductors, for example, we might see some overflow where there's less extension and rotation in the hips as well. There are a number of orthopedic surgeries that can ultimately impact tone and what we decide to do in terms of a seating strategy. Tendon releases can occur to a variety of muscles. Most commonly in people with increased tone can occur in the hamstrings, the adductors, the Achilles or heel cord. They're not actually releasing the tendon, so to speak, but lengthening it. And this is done by different strategies. Here you can see in this heel cord, tiny tears have been created within this to lengthen that area. Because it is lengthened, the muscle's not on as much of a stretch, and that can result in more available range, but also apparent reduction in muscle tone that can help us with our seating goals. In a VDRO, or varus derotational osteotomy, this is done when there's a shallow hip socket, often due to lack of ambulation in a client, and a femur that isn't very angled, and so the hip becomes very prone to dislocation or subluxation. And so the VDRO will do two things. It will take a very shallow hip socket and make it, there we go, a little more aggressive. And the top of the femur, it will help angle that so that we have a better connection between the two. This is usually attached with hardware that may or may not be removed later. Now, when a hip is rather free floating before a surgery like this, it can be a challenge in seating because the leg length might appear to change a bit because the femur is actually moving around in relation to the pelvis at times. A client may also receive a spinal fusion if there's a significant amount of curvature in the spine. Someone who's had a spinal fusion is very stable in their trunk, and it really makes our job as positioning that person much easier. There can be residual curvature that may still indicate a need even for a molded back to provide adequate pressure distribution for this client. Dorsal rhizotomy. Now, in my area, the Denver metro area, dorsal rhizotomies used to be much more common a number of years ago and then seemed to kind of fade away. They're making a comeback again, at least in my area, and sometimes instead of being done in the lower spine, in the lumbar area, are sometimes even being done in the cervical area. Either way, there's certain nerve roots that are cut, and that's going to impact whatever they innervate. In a traditional lumbar dorsal rhizotomy, the dorsal roots are cut and it's going to affect the lower extremities, but we may see some impact on the rest of the body as those muscles calm down, and it's often done so to improve ambulation. The baclofen pump has been around for a long time now. It's about the size of a hockey puck. It's placed within the abdominal cavity. A catheter goes from that pump into the cerebral spinal fluid through some of the vertebrae of the spinal column. It can be easily refilled and adjusted from the surface of the skin over the pump. It provides global results throughout the body in terms of tone reduction, more so below the level of where it's inserted into the vertebrae of the spinal column. The great thing about the baclofen pump is that person will require a fraction of the dose that would be required of oral baclofen, and so there's less side effects. Oral baclofen can lead to loss of trunk and head control, increased secretions, fatigue, and it also lowers the seizure threshold, and that can be a real problem for some of our clients. If we increase the baclofen, there's more seizure activity. But with the baclofen pump, since a smaller dose is required, sometimes clients are able to get that benefit of tone reduction without seeing those side effects, or at least they're not as extreme. Orthotics can also break up tone by providing some ankle flexion. In general, we'll talk about this more in our next course when we talk about seating strategies. If we can provide abduction, abduction, and flexion throughout the body, we can often break up some muscle tone for an individual. It depends on the individual, and that's more the case for people with velocity-dependent tone, like we see in cerebral palsy. A TLSO, or body jacket, can provide proximal support so the trunk doesn't have to work as hard. The point of the body jacket is to help minimize progression of a spinal curvature. Whether or not your area in your region, if the rehab physicians or orthopedic doctors are using TLSOs or not, it's going to vary quite a bit. In our area, it kind of goes up and down in usage, but it is important to determine, is this going to be worn in the seating system or not? Because it's hard to create a seating system to accommodate this orthotic some of the time, and then to provide adequate support when the client is not wearing it. So important to determine, are we creating a seating system around someone who's always going to wear this or who's never going to wear this? All right, now we're going to move into a very brief discussion of dynamic seating interventions, with an emphasis on helping people who have increased muscle tone. Now, within the Seating Dynamics website, we have other courses that go into more detail about just what dynamic seating is, that talk about a wide variety of available dynamic seating from Seating Dynamics and other manufacturers, and the clinical implications of using this. This is a brief discussion of dynamic seating around or within the context of increased muscle tone. So if you're interested in more information, I'd refer you back to the website to look at some of those courses. Dynamic seating is movement which occurs within the seating system and or the wheelchair frame, and that movement can occur at the hips, the legs, or the neck. The most common dynamic seating options are dynamic backs, dynamic footrests, and dynamic head support hardware. Now, dynamic seating will move in response to client forces, whether those forces are unintentional or intentional. This can include a rocking movement like we see here on the left. It can also include accommodating extension and dystonia that we see here on the right. So we saw a video of Amber earlier, but always good to relook and see that the system here is moving. She has dynamic footrests as well as a dynamic back in response to her extension and dystonia. And key to this working correctly is, despite the fact that she moves into quite a bit of hip rotation and extension, when she relaxes, she comes back into a neutral starting position, which is great. So dynamic seating absorbs these client forces and then stores that energy, kind of have to think back to physics, and helps return energy to help the client return to that starting position. That dynamic component that absorbs the forces may be an elastomer, a spring, a hydraulic, but the force from the client actually compresses that component. It absorbs the force, stores it as energy, assists the client back to upright as soon as those forces are reduced. So someone extends, they let up, and they're assisted back to neutral. Now, the design of the dynamic seating is exceedingly important. We want to make sure that these components can not only successfully absorb forces without breaking and return that energy, but we want that person to get back to a starting position without a loss of position in relation to the seating system. What often happens, let's say we just simply recline someone, we bring them upright, and they slide forward. We don't want that to happen. So the design of the component relies greatly on matching the natural pivot points of the client. So here we have a dynamic back, and you see that arrow there. The dynamic back is placed so that it's above the seat rail, the pivot point. That allows it to be about the same height as the natural pivot point at the hip. That allows the client to extend, come back to their starting position without the pelvis sliding forward into a posterior tilt. So let's talk about some of the primary clinical scenarios when we use dynamic seating. We're diffusing client forces that could otherwise lead to injury to the client, breakage or malalignment of the equipment, decreased sitting tolerance, increased agitation, decreased function, further increases in extension as this person's tone collides with a non-yielding surface. Instead, we want that surface to yield so that tone is diffused, and energy consumption. This young man has dynamic footrest, dynamic headrest, and dynamic back, and that movement is diffusing a great deal of his significant forces. Another primary clinical scenario is to allow movement to provide sensory input, increase alertness, and decrease agitation. Look, we all need to move, right? I've been moving around a lot during this session, and I'm sure you have too. We move for lots of reasons. We move because it's more comfortable. When we sit in one position without moving, our joints can become stiff. We may have unrelieved surfaces where tissues are compressed, etc. But also, we move for other reasons. We move because we're wired to move. We like to move. When I move, I might be more focused, more alert than if I just have to sit perfectly still. This is the same for our clients. Everyone really needs to move. Another application of dynamic seating is to improve postural control, stability, and function. This young lady here is able to self-propel her manual chair on nice, smooth, level surfaces. But when she went outside, she really couldn't push over any other type of surface like carpet or grass. She can now with her dynamic back. She actually leans into the dynamic back, and that returned energy that helps her come to upright actually helps her to push along the grass where she wasn't able to before. We can also see improvements in overall postural control. This young lady demonstrated better trunk and head control once she started using a dynamic back. And certainly, again, this has impacted her function. There's lots of other specific clinical applications as well. We're protecting the client from injury, protecting the wheelchair and seating hardware from breakage, increasing sitting tolerance and compliance. Someone's much more likely to use their seating system if they can tolerate sitting within it. We're providing vestibular input, also proprioceptive input. facilitating active range of motion within a limited range, increasing alertness, decreasing agitation, decreasing fatigue, increasing function, increasing strength and postural control, reducing active extension, and reducing energy consumption. Now, you might be saying, well, that's all easy to write down in a PowerPoint, Michelle, but is it true? There is research that backs up this information, and a lot of this can be found in the RESNA position paper on dynamic seating, and I would encourage you to look that up. It's under resources on the Seating Dynamics website. There's also a literature review that's posted there as well. So let's touch briefly on each of these dynamic seating products. So in a dynamic back, movement occurs only at the back. It can often be combined with other dynamic options to provide movement in other areas. Here you can see an illustration of the dynamic rocker back from Seeing Dynamics in action. So in the Seeing Dynamics dynamic back, resistance is adjustable through a set of elastomers pictured here. You can choose the amount of resistance that that individual needs, and we have some nice resources, including a very brief quick class, it's about 5 minutes long, about how to determine resistance in all of these products. Lockout is available on the dynamic back, and that can be useful during transportation, maybe over rough terrain, or during feeding as needed. But once you have succeeded in getting past that scenario, you want to unlock those again so the client is able to move as needed. Here on the left is JJ Peak from Seeing Dynamics demonstrating how the dynamic back works. And on the right is a client that I work with, Daniel. I'll go ahead and mute this. He's very excited because the Colorado Rockies are on, and that's his favorite team. And he has a lot of extension that happens at his knees and his back, as well as his head support. And this helps absorb those forces that in the past were leading to injury and breakage. In the dynamic footrest, movement can occur in different directions, telescoping downward, elevating outward, and even ankle and plantar and dorsiflexion. In some products, the foot plates also can rotate outward. This can also be combined with a dynamic back or a dynamic head support or both. So the dynamic footrest comes standard with a telescoping feature that moves about 1.5 inches downward. There's 3 different springs that come with this with varying resistance. The medium level is the default, but you can change it out to the others. I really like that there's a variety of resistances available in these products so that once it shows up, I can adjust it for that individual. Sometimes we only want the telescoping feature. Well, why? It might be this client has such tight hamstrings that they really can't elevate their knee, but we still want to absorb some of that force. We can at least let that force move downward. There's also an optional knee pad that you see pictured here if the client is making contact with that hardware at all. But probably the most common order that we receive, and what I usually recommend for my clients, unless they have those really tight hamstrings, is a combination of telescoping and knee extension, because this basically follows the natural arc of our knee during extension. So there are elastomers that provide this knee extension. Medium is the default, but they could be changed to soft. There's also available a dorsiplantar flexion option. This isn't going to be as indicated for someone perhaps who has AFOs that they're wearing all the time, but for many clients, when we have that extension that occurs in the hips and knees, it also occurs in the ankle, and this can further diffuse that force. And here we have some videos illustrating this again. On the right, we have JJ, who's demonstrating the telescoping, the knee extension or elevation, as well as movement of the ankle. And on the left, This is a client that I work with who is showing extension. Sometimes his body extends more on one side than the other. Sometimes both legs extend at the same time. You can even change the elastomers so there's a little more resistance on one side than the other if that is more applicable for an individual client. This removes the leverage for this young man that he used to get off of his foot plates. He would previously stand on his foot plates and basically stand within his wheelchair seating system. Now, this smooth movement just takes the wind out of his sails. He can't get that leverage. He's able to stay seated and more functional within his seating system. And then finally, there's the dynamic head support hardware. Movement can occur in multiple directions. So there might be direction anterior, posterior, bidirectional. It might be multi-directional. Regardless, it's very important in the design to make sure that we're avoiding the person moving into neck hyperextension. We want simply the head to move rearward. And again, this can be combined with other dynamic options. The seating dynamics dynamic headrest moves anteriorly and posteriorly about 10 degrees, but it really depends on the force of the client and how many links are used to get the head support where you need it to be. It responds to both posterior and rotational movement, which is great because many of our clients, as they extend, also have some rotation, particularly if there's some of those reflexes going on, like that ATNR. You can change the resistance as needed, and it can be used with lateral component hardware and or a suboccipital pad adapter. Basically, that means you can use this with almost any set of head pads on the market. You order those separately from that manufacturer, but this is compatible with most of them. So you can attach that occipital pad, but if the client requires, you can also attach a suboccipital pad and lateral pads. And I often do that with many of my clients. So it's nice to have these options on the hardware. More recently, this also includes a lockout feature that you can see pictured on the lower left. This allows the dynamic head support hardware to be locked out during transport or if you're moving over rough terrain, during feeding as needed. The rest of the time, you can leave this in an unlocked position.
Okay, go.
This is a client I work with who has a lot of tone, and he is readily moving this when he extends. He also has other dynamic components. I believe the dynamic back at this point on this chair was not yet installed. He's trying this out. And lots of movement here. He was chronically breaking and moving out of alignment his other head supports, and this has prevented that. All right, so what's our take-home message? Well, positioning clients with high muscle tone can be really challenging. Optimal seating can help to inhibit muscle tone and optimize function. Tone management can be a big help as well. It's important to keep in mind that many clients with increased muscle tone may also have movement patterns and reflexive patterns that we also need to keep in mind in crafting a solution for this client. And dynamic seating can also be a real critical part of our overall wheeled seating solution. Now, if you have any questions about what's been covered in this session, please contact us. I'll show you our contact info in just a minute with any questions or if you want further information. I want to thank you very much for attending this course here today. We know everyone's super busy. We appreciate the time you take to increase your knowledge and to increase the services that you provide to the clients that you work with. And here's our contact information. Again, if you have any questions, reach out. There's lots and lots of resources on the website that you can check out. And keep an eye out for an announcement about part 2 of this series, where we'll go into general seating strategies when you're working with people who have increased tone. Later in 2023, we're also going to have a CEU approved course on head positioning. So I hope you can join us for that one as well. So again, thanks everyone very much. We appreciate your time and hope to see you for a future event in the future. Have a good one. Bye-bye.